Okay, so we shall start. Very warm welcome from Emirates Society of Internal Medicine. I am Dr. Omar Al-Hammadi, the Vice President of the Society, Consultant Internal Medicine Physician in Al-Rahba Hospital in Abu Dhabi. In the name of the Society, I would like to thank all guest speakers and audience from inside and outside UAE for attending this session, Monkeypox for Healthcare Providers. The COVID pandemic was a long, ongoing learning lesson for all of us. We started with the unknown, moving to the known. We learned everything about it from the scratch: etiology, pathophysiology, transmission, clinical manifestation, medications, and vaccination. I think with the monkeypox, we have slightly different story and better story. We are moving from the less known to the more known. We have fairly good background data about different medical aspects of the disease. The aim of this session is to show what we knew in the past and what we need to know in the present and what should we expect in the future. Healthcare providers, including doctors, nurses, allied health professionals, they are all hungry for the evidence-based information we will present today. We have more than 1,000 people who have registered to attend this session because they want to hear from the experts. We are so lucky to have all of them with us today on one table: infectious disease, dermatology, internal medicine, microbiology. I think this is just a great virtual gathering. Unfortunately, we don't have tea, coffee, or biscuit to offer, but I promise we will have refreshing information from the speakers. I will leave the floor to the chairperson to introduce the speakers, and I will be back with the questions in the end of the webinar. If you have any question, please post it in the chat box, and if you write the name of the speaker you would like to hear the answer from, that will be great. Dr. Ahmed Al-Hammadi will be the chairperson. He is consultant infectious disease in Tuam Hospital. Dr. Ahmed, you have the mic.
Thank you very much, Dr. Omar, for this very warm introduction. Good evening, everyone, to all the participants. And today we have a panelist of 6 wonderful speakers that we all enjoy and learn from every day. So without further ado, I would like to introduce the first speaker, who's Dr. Fatima Al-Dhahri. Dr. Fatima Al-Dhahri is a pediatric infectious disease consultant with expertise in infectious disease in the immunocompromised host. She completed her ID fellowship at the Boston Children's Hospital in Boston, an affiliate of Harvard Medical School. And she also completed pediatric residency program at the Children's National Hospital Center, an affiliate of George Washington University. She also completed additional training in the pediatric immunocompromised host infectious disease specialty pathway at Boston Children's Hospital, and she's currently working as an assistant professor in the Department of Pediatrics in UAE University and a consultant pediatric ID at Sheikh Khalifa Medical City and Emirates Organ Transplant Committee. Dr. Fatima, welcome, and thank you for joining us today.
Thank you so much, Dr. Ahmed. Thank you for this kind introduction. I'm gonna go ahead and share my screen. Okay, so here we are. It feels reminiscent of 2 years ago. Again, very humbled by viruses, this time a different kind of virus. So within 15 minutes, I'm hoping to cover the following outline. I'm gonna go over the virology, the history and origin, the viral characteristics and geography, epidemiology timeline, and the global health implications. And I'm very excited to learn from the other panels as well. So the monkeypox belongs to the genus Orthopox virus from the family Poxviridae. Its other members include cowpox and variola virus, which the world knows as smallpox. Since the global eradication of smallpox with historic mass vaccination and ensuing herd immunity, monkeypox has emerged as the most prevalent orthopox virus infection in humans, and that actually is postulated to sort of set the stage after the disappearance of smallpox. I'm sure many of you from the healthcare field know about the classic picture of 1901 of two brothers, one vaccinated and one not. And I don't have to point out who is vaccinated, who is not, but the mass vaccination ended in the late 80s, and smallpox was the first human infectious disease declared empty off of the face of the earth. So maybe the success of something led to the emergence of another. So monkeypox primarily occurs in the rainforests in West Africa and Central Africa. Although antibodies have been detected in a range of small mammal species, really the reservoir remains unknown. But it has been detected in primates and small rodents. As you all know, you've seen pictures already in the newspapers. The name monkeypox originates from the initial discovery of the virus in monkeys in a Danish laboratory in 1958. But the first case actually in humans was diagnosed in 1970 in a 9-month-old baby boy in Zaire that is now the DRC. And so you can see that the jump happened, meaning this is a zoonotic disease. Some postulated sort of driver of monkeypox infection from animal to human is really contact with the animal reservoir, including contact with either live or dead animals via hunting, preparation, or bushmeat as food. We've seen over the course of decades how, especially in the continent of Africa, since it's been discovered in the 1970s, closer and closer contact between humans and animals through deforestation, demographic changes, and climate change, hunting, population movement. This has been exacerbated by civil war and population displacement, forcing inhabitants to sort of go to alternative sources of protein. And that's where sort of bushmeat comes into place, or consumption of animals that carry the reservoir of the virus. So like I said, the monkeypox originated in the continent of Africa. It's subtyped into two clades. There's the Central African clade, prevalent in the Central African Republic, really mainly in the DRC, or Democratic Republic of the Congo. And this type of clade causes more severe illness, and the case fatality is up to 11%. And then there's the West African clade, mainly found in Nigeria, and this subtype causes less human-to-human transmission. It causes less severe illness and death in up to 6% of cases. The current outbreak, the one that started in Europe and is spread out of the EU countries, is linked to the West African clade after it was genetically analyzed. This is a typical MMWR report from the CDC. This was in 2018. The title says it all: emergence of monkeypox, West and Central Africa between 1970 and 2018. And I highlight a couple of things here. The reason it is relevant to the US is because in 2003, the US had its own outbreak of 47 confirmed and probable cases, and that's from imported rodent from the African continent. As you can see highlighted that in the DRC, monkeypox is prevalent. They report more than 1,000 cases yearly. That's in the central sort of region, and then the West African region, Nigeria. And back in 2018, Nigeria has been reported the most cases in the West African region. This is a quote directly from the report. Again, remember, this is 2018, so pre-pandemic, pre-COVID-19 pandemic. Quote, the emergence of cases is a concern for global health security. So this has been known to the global community for years now. So this is not something new. I want to walk through an epidemiology timeline. So like I said, the first case was discovered in the 1970s, a total of 48 confirmed and probable cases in 6 African countries. Most cases was in the DRC. And in the 1980s alone, so comparing to the decade prior, there's been a 9-fold increase compared to the 1970s. And you can see the jump in the numbers alone in the DRC with an N of 343. And then fast forward to the 90s, where the cases continued to rise with cases in the 500s. And between 2000 and 2009, it continues to be reported in at least 3 African countries. And this is when the 2003 imported case happened in the US. Between 2010 and 2019, cases were found in seven African countries. And then you have your first imported cases outside of the African continent, besides the US, to the UK, Singapore, and Israel. So this is a image depiction of sort of the decade progression between the 70s and in the decade prior. As you can see, it has been confined to the continent of Africa for a very long time. So what do we know of the current outbreak? So I'm talking about 2022. So the first case linked to travel from Nigeria of monkeypox was diagnosed in the UK on the 7th of May. And then on the 14th of May, a familial cluster of 2 cases with no relation to the prior case reported May 7 was discovered. This was sort of the first line where there was no clear connection between travel from the African continent. And then fast forward to May 25, a total of 118 confirmed monkeypox cases have been reported from 12 European members of states. And this map sort of depicts where it started in the UK. So what do we know of the current epidemiology that started in the UK and spread to EU countries and later to non-EU countries? Most cases were in young men self-identifying as MSM or male who have sex with male. There have been no deaths. And really those cases have been mild in clinical presentation, mostly presenting in the lesions of the genitalia or perigenitalia area. This is the first time that the chains of transmission are reported in Europe without known epidemiological links to West or Central Africa. And actually, this is the first cases worldwide reported among MSM that we know of. This is from the most recent report of the WHO, depicting the global cases outside of the African continent. So as you can see, I highlighted several countries that have sort of a spike: Canada, the US. Again, these numbers are per the 26th of May. So there might be more cases there. At least the US, it's now in 12 states at least. Netherlands, Portugal, Spain, and the highest cluster remains in the UK. Totaling 257 cases in 123 countries. This is a table from, because the WHO continues to survey the African continent. As you can see, cumulative cases are the most in the DRC, and deaths too. There's been reported deaths as well. This has not been the case in the outbreak in Europe and in non-EU countries. This is also like a global depiction. As you can see, we're that small dot that our current burden is not a lot compared to the other countries. The ones in red dots depict at least more than 20 cases. This is the report updated as of the 26th of May. So the WHO risk assessment, when you read the actual report, is that it certifies this global risk as moderate, and reports that the virus might have been circulating unrecognized for several weeks. And then the public health risk could become high in populations like children and immunocompromised populations. But then we need to remember that a large part of the population is vulnerable because the cross protection that the smallpox vaccine gave, the immunity is waning. This is my last slide. I'm gonna leave you with this. This is a New York Times article, and the title says it all: to fight monkeypox, remember the lessons from COVID and HIV. We can't stigmatize this disease. We need to learn from the lessons we learned from HIV. And then this is a great physician scientist, Dr. Titanji. And this tweet says it all. If you're not on Twitter and following IB Twitter, please do. You learn a ton. And I'm learning a ton from her. And she's basically saying that when she published this tweet on the 20th of May, that the numbers detected outside of the continent Africa has far exceeded the numbers since the 1970s. So we had more than 50 years to prepare. So just to bring this home, that monkeypox have been going on, but sort of outside of the eyes of the developed countries and happening in low-income countries. And with that, I am gonna stop sharing.
Okay, thank you very much, Dr. Fatma, for this very nice presentation and a wonderful introduction into the subject. I would like, before that, to point that we already have more than 900 participants and 2 questions. So if anyone has any question, please add it to the Q&A section, and we'll be happy to address that at the end of the session. Our next speaker to discuss about the diagnostics for monkeypox is Dr. Palat Minan, MBBS and PhD. He's as a clinical microbiologist with over 40 years of experience as a physician and microbiologist, and has over 50 publications. He's the founder and CEO of Astragene, the UAE's first molecular diagnostic manufacturing company. Dr. Minan, the floor is yours.
Thank you. Thank you very much. I'm going to share my screen now. Is my screen visible?
Yes, we can see.
Thank you. So I will be covering the laboratory investigation of monkeypox. I will not go through the slide. We have already covered this, initially discovered in 1958. And the interesting thing is that many genetic changes responsible for more efficient human transmission have now been hypothesized. So this is very important. Belongs to the family Poxviridae, subfamily Cordopoxvirinae, and orthopox virus is probably the most important in this genera. Monkeypox virus is a double-stranded zoonotic virus, causes monkeypox in humans and other animals. Monkeypox is similar to smallpox with a milder rash and lower mortality rate. This is a diagrammatic, schematic diagram of the monkeypox virus. It is a double-stranded virion. It has got an envelope. It has got multiple molecules which go and bind to the human cell, and it fuses with the human cell, enters the cell, causes transcription of the DNA, and manages to reproduce itself. So this is a very brief input on that. As pointed out, there are 2 clades, the Central African clade and the West African clade. You can see a study which has been done, which looked at the genomic structure of these viruses and its relatedness. And there's a distinct difference between the severity of illness caused by both these clades. Now we'll jump directly into sample collection. So as infectious disease physicians, we have to be extremely careful. We got to wear personal protective equipment. We got to ensure that we do all the actions required for appropriate hand hygiene, and also important to decontaminate the environment before and after the patient has come and visited you. I will be covering on which specimen to collect, how to collect, and various aspects of specimen collection and transport. It is important to point out that this data has been taken from the WHO website. There is a very nice MOOC available, which gives you a certificate course free of cost. In about 4 lectures or so, tells you a lot about the monkeypox virus. So I recommend anybody interested should, go onto the website and study this very, very important material given there. So which specimens to collect and when? So during the incubation period, no sample is expected to be collected. It's usually 5 to 21 days. Then comes the febrile stage for about 1 to 4 days, where a nasopharyngeal swab or oropharyngeal swab can be collected. Then comes the rash stage, which may last anywhere between 2 to 4 weeks. And here the lesion fluid, the lesion roof or lesion crust should be collected. Finally, during the recovery phase, serum can be collected for antibody studies. So this is the broad spectrum of samples which can be collected. Of course, pre-analytical precautions of sample labeling, etc., are very, very important. Patient's name, surveillance number, place of origin, date of sampling, all these are very important. The type of specimen to be collected, and cross-check that information on the tubes vis-a-vis the case investigation forms and see that they match. Very, very important. Pre-analytical variables are responsible for a lot of lab errors, so one has to be extremely careful when it comes to collection of sample. So I have made a list of the oropharyngeal swabs and consumables. You can use a dry polyester swab, dry swabs, collect the sample, put it into a screw cap plastic tube. The swab procedure itself is fairly simple. We are all experts now with COVID around. Ideally, brush a vesicle or the tissue with the swab, put the swab into a container. There have been differing recommendations on whether a dry swab can be sent or you can send it in VTM. I think both should be all right. When it comes to collection of samples from the lesion roofs and fluid, you need to collect all the material required, collect an alcohol pad, collect a sterile blade, a swab, and some screw cap plastic tubes. Sanitize the lesion nicely with the alcohol pad. Cleanly remove the lesion roof, brush the lesion base, put the swab into the container, and put the roof into a separate container. So send this directly to the lab as quickly as possible for testing. When it comes to lesion crust, again, the similar procedure: take the alcohol pad, a sterile knife, and some screw cap tubes. Sanitize the lesion, remove the crust, and put the crust into a container. So very simple. Serum, I will not talk much about because we all know how to collect serum, collect whole blood, separate the serum as quickly as possible, transfer into vials, store the serum at -20 degrees centigrade as quickly as possible. Keep the specimens at 4 degrees centigrade during transport, store it in a freezer at -20 degrees centigrade, prior to testing. Specimen transport, please follow all the biosafety precautions, use the fastest mode of transport, and temperature at around 4 degrees centigrade is vital to be maintained. Then when you reach the lab, currently the best mechanism of diagnosing the infection is PCR-based technology. So the first step which one does is to extract the DNA. There are multiple methods to extract DNA. You have an automated method, which is now present in almost all the laboratories, courtesy COVID. And then you have the manual method where you can extract the DNA using a spin column. Then, of course, then comes the PCR itself. Currently, there are no kits available for diagnosis of monkeypox. Only kits available are RUO, that is research use only. So it's imperative that samples which are collected should be tested in the laboratory using the RUO kits with adequate primers, probes, and controls, ensuring that the kit is validated as a lab developed test. We call it LDTs. So it's important to develop the LDT in your laboratory, and there are two modalities which, after surveying the literature, which can be used. One is a generic PCR where you have two primer sets. One is the internal control, which is any housekeeping, any human housekeeping gene. And then you have the clade you have the one primer probe set, which is common for all the, both the clades of clade 1 and clade 2. Then you have the clade-specific PCR, which differentiates between clade 1, which is the Central African clade, and the second one, clade 2, which is the West African clade. The generic target involves the TNF receptor gene of the monkeypox virus, and a portion of the TNF receptor receptor gene is used to identify the West African clade and the complement binding protein gene of the Congo basin clade is used for the Congo basin clade of the virus. Most of the kits suggest using RNA-SP as an internal control. On the right side, you can see a PCR instrument. I think everybody knows about it. And then you can see the amplification curves obtained on the PCR in case the sample is positive. For more information, there is, as I told you, there's a very nice MOOC course available and a lot of publication available from WHO. And anybody who wants this presentation can just reach out to me. I'll send you all the details, including the references. Thank you very much.
Thank you very much, Dr. Menon. This is a very important part to discuss about how to collect the samples and to do the test. I think many of the important aspects lie behind this. I would like to remind everyone that please, if you have any questions, please add it to the Q&A section. Our next speaker is Dr. Emmanuel Sutibo, is an ID consultant, physician and the chairman of the Department of Tropical and the Division of Infectious Disease at Sheikh Shakhbout Medical City, Abu Dhabi. He chairs the Hospital Infection Prevention Committee and is also the chair of the African Sepsis Alliance and an investigator for the African Research Collaboration on Sepsis. He's a clinical advisor on the National Health Services England for Sepsis and Deterioration, and is a member of Global Sepsis Alliance Board and Executive Committee and a member of the Sahha ID and Infection Control Council. He has special interest in several bacterial infections, MDR infections, TB, HIV, quality improvement, patient safety, and clinical leadership. Dr. Sutibo will be discussing regarding the management of monkeypox. Dr. Sutibo.
Thank you, Dr. Ahmed. Thank you for that kind introduction. I'm just going to share my screen and then I will start presenting. Thank you. So it's a pleasure to be presenting at this really important event. So thanks to the organizers. I'm going to focus on clinical management of monkeypox. And in doing so, I want to answer 3 questions that I think as clinicians, you'll be asking yourself if you look after a patient with monkeypox. The first is, what are the possible complications? What about mortality? And what are the prognostic factors to predict poor outcome? Secondly, what's the mainstay of management in terms of preventing and managing complications? And then lastly, what about antivirals? What is the role of antivirals in treating monkeypox? So let's start with the first question, complications, mortality, and prognostic markers. Just like chickenpox, the complications of monkeypox are viral, but also bacterial. And the direct viral complications, monkeypox can cause inflammation in most organs, typically because the rash affects mainly the face and extremities. You can also have lesions in the eyes causing keratitis. So you have complications related to the eyes, such as keratitis, and that can lead to blindness. But it can also cause encephalitis and also pneumonitis, viral pneumonitis. Like chickenpox, you also have bacterial superinfection, and that tends to happen in the skin, on the skin most commonly. Around 20% of the bacterial infections that occur are from the skin, and that includes skin and soft tissue infections such as cellulitis, but that can also develop into abscesses. Now, smallpox, especially the severe forms, monkeypox, especially the severe forms, can also cause abscesses in different parts of your body. And that can be retropharyngeal abscesses causing obstruction, or abscesses under your skin, subcutaneous abscesses, or even pyomyositis. And there have been case reports of viral abscesses as well as bacterial abscesses. Now, all this can lead to sepsis, and the most significant cause of mortality in these patients is sepsis, either caused directly by the virus or by bacterial infections. You also have long-term sequelae in these patients with the rash that can develop. They can then develop scarring and loss of pigmentation with disfigurement, and also corneal ulcers leading to blindness. And in pregnancy, it can cause severe infection with stillbirths and also miscarriages. I'm just going to stress this again. The current variant, the current clade of the virus, the West African monkeypox clade, is associated with low mortality. Mortality is probably 1% or less. In terms of risk factors for severe disease, age, young age, children under the age of 8 years, immunosuppression, especially with HIV, and pregnancy and other comorbidity are factors that are associated with severe disease. And what about the optimal management? Well, management focuses really on supportive care. Most of the patients with the West African clade of monkeypox will have mild disease, and therefore the treatment is predominantly supportive, looking for and preventing and looking out for complications and treating them early to avoid morbidity and mortality, treating fever and pain with appropriate analgesia and antipyretics, and making sure the patient is well nourished and well hydrated. But let's focus a bit on the skin and mucosa, where the highest amount of, in terms of morbidity, infections tend to happen. Well, keeping the skin washed with soap and also antiseptic to reduce the risk of bacterial infections, and then spotting and treating localized or systemic bacterial infections when they occur with topical or systemic antibiotics, good eye care with eye padding when necessary, or eye drops, antibacterial drops to prevent and treat bacterial infections, and also giving vitamin A, which is associated really with good healing skin and also eye health. And then mouth care with a mouthwash, antiseptic mouthwash, or salt and water, and using analgesia, oral analgesia, to reduce the pain associated with the mucosal lesions. Patients with monkeypox, because of the stigma and isolation and the need for prolonged isolation, tend to have a lot of anxiety and depression. So if you looked after these patients, you need to really focus on psychological support, telling them what they should expect and giving them a lot of information about their care, providing individualized care and meeting their specific needs that may involve specific food, paying attention to also religious needs, if they need a Quran, for example, to be given to them there. When we looked after such patients in Liverpool, we used technology to help provide the care. So nurses and doctors should communicate with the patient frequently with the help of Zoom, for example, and other forms of communication, and so they also have access to communication to their family and their relatives, even though they're isolated, and that really helps to boost their morale. So you need to focus also on psychological support. So what is the role of antivirals? Quite an important topic. Well, there are two antivirals that have potential for treatment of monkeypox, brincidofovir and also tecovirimat. Now these are have shown quite a lot of promise in animal studies, but the caution is that there's been no published trial in humans, and there've been very few observational studies of use of these antivirals for treating monkeypox in humans, apart from the one which I'm going to go through in a minute, which is a UK-based study published last week in the Lancet, experience from the UK High Consequence Infectious Disease network led from Liverpool. So most of the data is extrapolation for efficacy of using these drugs to treat monkeypox, smallpox, or cowpox in animal models, not humans. And I'll show you that. Let's look at the first drug, brincidofovir. The data we have suggests that it shows a trend towards a protective effect in an animal model. An example is the study in prairie dogs, where brincidofovir appeared to confer some modest survival benefit, with survival of 29% versus 14% in patients that in prairie dogs infected with monkeypox that did not get this drug. So this is data from prairie dogs, rodents. So the FDA, based on the animal studies, decided to approve this drug for the treatment of smallpox. Let's look at what data we have for brincidofovir for treating monkeypox in humans. What data is there in humans? Now, this is the only study published last week in the Lancet Infectious Diseases from the UK experience, led from Liverpool. And they put together a case series from monkeypox cases in 2018, 2019, and 2021, managed as part of the High Consequence Infectious Disease Network in Liverpool. And I was involved in the 2018 cases when I was working in Liverpool. Let's look at the data from the case series. Now, the first case which they published in the Lancet is this patient, and they used brincidofovir 1 dose in this patient. It's given once a week, so this is 1 dose given to the patient. What they saw was no change, no effect, no clinical effect in the patient in terms of the rash or symptoms, but they saw a reduction in the viral load, monkeypox viral load in blood, in the throat swabs, upper respiratory tract, and also in urine. But that may just be a temporal relationship with improvement of the patient anyway. The second case they described, where they used brincidofovir 2 doses, 1 week apart, 2 doses 1 week apart, and they didn't see any clinical improvement in the patient, but they saw a reduction, temporary reduction in viral load in blood, urine, and upper respiratory tract when it was given as 2 doses. And in the third case, again, similar experience, 2 doses of brincidofovir 2 weeks apart. They saw a reduction in temporal reduction in viral load, no improvement in clinical symptoms. And what was most important in this case, and highlighted in red, is because of the absence of clinical improvement, they found this patient had an abscess in the thigh and also in the ankle. And the only clinical improvement they got was when the abscess was drained on the IR. And growth bacterial cultures on the fluid from the abscess was negative, but had quite a high monkeypox viral load in the abscess fluid. So this was more like a viral abscess as compared to a bacterial infection. And draining that abscess is what led to significant improvement rather than antivirals, brincidofovir. The main side effect of brincidofovir is deranged liver function tests, and all the 3 patients that were treated in 2018 in Liverpool had significantly deranged liver function tests, as you can see here, with ALT going up to close to 600 in 1 patient. The other drug is tocovirimat, and it inhibits viral protein 37, which is a protein that is common for the orthopox viruses, and therefore prevents replication of the virus. It has very good bioavailability orally and is usually given for 14 days. The data is predominantly also from non-human primates, monkeys, where tocovirimat has been demonstrated to have a protective efficacy when smallpox and monkeypox is given to the monkeys and then they're treated with tocovirimat. And I'll show you some of that data. So based on the animal studies, predominantly, it's been licensed for use for smallpox in the EU and EUA, and FDA has licensed its use for smallpox, but also for monkeypox. So this is one of the studies done in monkeys challenged with smallpox and then given either placebo or tocovirimat on day 2 and day 4. And what you see is that the viral load in the throat for the monkeys that were given tocovirimat reduced quickly, and the mortalities appeared to be more in those that were given placebo rather than tocovirimat, even though it was not statistically significant. There's also a case report of use of tocovirimat in treating orbital cowpox, which is another orthopox virus, and it was quite a case a published case of effective treatment of orbital cowpox using tocovirimat. So tocovirimat use in humans, the only published report is the experience in Liverpool published last week in the Lancet. And it's this patient treated in 2021 with tocovirimat and with patients who had monkeypox. And they gave 14 days of tocovirimat with a rapid clinical improvement in the rash, but also the viral load, monkeypox viral load in blood and upper respiratory tract seemed to reduce very quickly with use of tocovirimat. So again, this is the only, but it's only experience used in humans with monkeypox, but it's signal that tocovirimat is likely to be quite effective in humans, extrapolating also from the animal model. So I'll conclude with take-home messages. The first is mortality in the current outbreak is low, probably less than 1%. Most patients have mild illness. Preventing and continuously assessing for complications and treating them early, especially bacterial superinfection, is really important. Supportive care is the mainstay of treatment for patients with monkeypox, and that's where the focus should be. But there is a suggestion that tocovirimat is a promising option, but we don't have strong evidence of its effectiveness in humans, but that needs to happen. And there's a current trial going on in Central West Africa, assessing the effectiveness of tocovirimat in monkeypox in Africa, and that will provide very useful data. I want to finish by acknowledging the team in Liverpool and in the UK that I used to work with in 2018 before I moved to UAE, who published the paper in the Lancet, and some of the slides were provided by one of the registrars who has been working on monkeypox in the UK in Liverpool, Hugh Adler. Thank you very much, and I'll take questions at the end.
Thank you, Dr. Stibo, for this very nice and interesting lecture, and thank you for sharing your knowledge and experience on the subject. Our next speaker will be discussing regarding the prevention and vaccination strategies. Dr. Nawal Al-Kaabi, she is a graduate from the UAE University and is an American board certified in pediatrics in 2001, certified in global research by Harvard University in 2015, and also certified by the American Board in Quality 2017. She obtained her CPE, Certified Physician Executive, from the American Physician Leadership Association in 2019. She's also a fellow of the pediatric through the Royal College of Physicians in Canada in 2002, and again in pediatric infectious disease in 2004. After that, she completed an infection control fellowship at the Children's Hospital of Eastern Ontario, University of Ottawa in Canada. She is currently the chair of Saha Infectious Disease and Infection Control Council. And during the COVID pandemic, she has been assigned as the chair of the National Clinical Committee for COVID and principal investigator of multiple clinical trials. I personally enjoy and learn from Dr. Nawal every day. Dr. Nawal, the floor is yours.
Thank you, Dr. Ahmed, for the introduction, and I'd like to thank the Emirates Internal Medicine Association for arranging this important webinar. Give me just a second. Can you see my slides?
Yes, Dr. we can.
Okay, thank you. So I'm going to talk about the transmission, infection control, vaccination, and briefly about the risk assessment, especially that I have only 10 minutes. So in terms of transmission, it required direct or indirect contact with the body fluid or lesions, contact with vomits, or exposure to respiratory secretions. Typically, it was also contact with animals, but we are talking about the current outbreak. So it is very important for the healthcare provider to recognize the case and isolate it as soon as you a case, whether you are in emergency room or even if you are in the outpatient setting, and you need to inform the infection control practitioner and infectious disease. Actually, in UAE, we said that all cases we have to consult infectious disease to decide if this is a suspected or confirmed, if it is a suspected case or not. Confirmed later on, you will identify it. You have to limit the number of healthcare personnel who look after this patient, whether in outpatient setting, ER, or inpatient. And currently, our recommendation is to admit all patients. Of course, we have a limited number, so we can manage all admission at this stage, and everyone should follow their local health authority. If the patient has skin lesions, It's better to cover, if possible, the skin lesion. Ask the patient to wear long sleeves and long pants. In terms of the main risk of transmission, actually, it's contact with the skin. And usually it is a prolonged contact. Also, contact with cloth or linen can increase the risk of transmission. Respiratory droplets is another mode of infection transmission. And there is a theoretical, because it's an emerging infectious disease, we are applying the airborne, although we don't have an evidence that it is an airborne. But at this stage, because of the theoretical risk, all patients will be admitted under airborne precautions. And if we don't have an negative pressure room, then we'll go with a single room with a HEPA filter. So for any patient, we have to follow standard precautions, contact precautions, droplet precaution, and as I said, airborne precautions. If the patient, for whatever reason, required intubation or extubation, or you have to perform any aerosol generating procedures, then we have to follow airborne precautions. This is from the European CDC risk assessment for the broader population. So in general, for broader population, the risk is low to get the disease. And the individual at high risk of complication are children, pregnant women, elderly, or immune compromised. Now, the risk low to high for health professional depends, of course, on the type of exposure. If the healthcare worker are wearing protection, PPE, it is a low risk. If they are not protected, it is a moderate risk. Laboratory personnel, it is a low risk if they are following appropriate biosafety procedures. And of course, if they are not, then it will be a higher risk. And overall, risk possibly higher for those who are older or immune compromised. This is a very good for reference from the European CDC. It defined the close contact. Of course, you need to follow your local health authority definition of a close contact, but this gives you an example. What is the close contact? So the sexual partner is a close contact. The person who lives within the household is a close contact. The person who share clothes, bedding, utensils, sharing the same. So if they are living together in a dorm and they're sharing a lot of things, it is considered a close contact. Military camp is a close contact. Labor camp considered a close contact if they are living multiple persons in the same room. Prisons also is a close contact. So healthcare worker without proper precautions, they are close contact. And I did already talk about laboratory. I think that we receive a lot of questions nowadays for those who are traveling. So co-passenger seated 1 or 2 seated distance around the case, they are who were symptomatic, they are considered close contact if it is 8 hours and above. So short flight, not considered a close contact. And actually, I tried to review if there is any evidence that disease transmit during flights, and I couldn't find anything. However, it will be considered close contact if it is 8 hours or above. Most of other contacts are considered not a close contact. In terms of vaccination, so there are 2 options, the smallpox vaccine and 3rd generation, which can be effective against smallpox and monkeypox. Now, the smallpox, we are not using it as Dr. Said mentioned earlier, and many people are immune. Those who are born, I think in the 70s, late 70s, early 80s, probably they are not immune. And even those who are born in the 70s, some of them, they are not immune if the family refused, or it happened that when they went around the houses, they were not in the house. And how you can know, of course, you have to, you can ask your mother or your father, but the scar is very distinctive. And the reason the scar is very distinctive is because they use those tiny needles, and they use multiple punctures to administer the vaccine, and it leaves a scar. I left this picture to show you why the scar happened. And look at your upper arm. If there is a scar, maybe most likely you received your smallpox vaccine. If you don't have any scars, and unfortunately I'm not young, but I don't have any scars, so I think I am not immune. And I confirm it with my family that I didn't receive the vaccine. So historically, there is first and second generation smallpox vaccine that can be used. And these vaccines are reactogenic and associated with risk of other serious adverse events. However, the newer third generation smallpox vaccine that can be used also for monkeypox are much better and less side effect. The one that's been ordered is the MVA vaccine. It is a third generation, and it is approved by the European Medicine Agency in 2013 for prevention of smallpox, and approved by FDA in 2019 for the prevention of monkeypox and smallpox. So what it is, the MVA, it's sold under different name in different countries. It is highly attenuated, non-replicative vaccine, virus vaccine. Excellent safety profile, and even used in can be used in immune compromised, can be used in pregnant women, can be used in children, and also can be used in those with skin disorder. It is usually 2 doses. And the efficacy, the initial efficacy studies was from animals. It showed that it is effective in animals. This is a good study if you can review it, published in New England Journal of Medicine. And they have 440 volunteers randomized to receive single dose of ACM, which is second generation smallpox vaccine, or 2 doses of MVA, which is the third generation. In a simple word, it showed that it is immunogenic. Even the immune response was higher than the ACM 2000. And it showed that it didn't produce a skin lesion, which typically we used to see with the first and second generation smallpox vaccine. In terms of how long it will persist, the antibodies with MVA, roughly, we don't have a good data, but the data that is available roughly around 2 years. After 2 years, those who are at high risk of catching the disease, they will need 1 booster dose. This is a good slide from the CDC. It showed how the difference between the 2 vaccines in short time, I think, but briefly, MVA is effective and less side effect, and much less side effect in terms of both serious and cutaneous side effect than the second generation. In November 3rd, 2021, the ACIP in US, they recommend the MVA for certain people, including lab clinicians who could be exposed to orthopox virus. In terms of contraindications, the contraindication for the ABM almost null unless the patient had serious vaccine allergy from the previous component, but can be used for all these indications. I think there's no time for post-exposure, but there's clear guidelines, both in UK guidelines and the CDC, who can receive post-exposure, mainly those who are at high risk. And it defines what is the high risk post-exposure. This is a very good recommendation by UK Health Security Agency for pre and post-exposure. I'll skip this part, and I'd like to thank everyone. Please remember to update yourself and don't panic. If you see any case, just follow the precautions and you will not catch the disease. Thank you so much.
Thank you very much, Dr. Nawal Kaabi. We come to our last and one of the best speakers we have today is Dr. Anwar Hammadi, is a consultant dermatologist at DermaMed clinic in Dubai, and he brings more than 15 years of experience in the field of dermatology. He's certified by the American Board of Dermatology and is a fellow of the Royal College of Physicians in Canada. In 2015, also, he became the president of the Emirates Dermatology Society. Dr. Anwar will be discussing about the rash differential. Welcome, Dr. Anwar.
Thank you very much, Dr. Ahmed. I'm just trying to share the screen. I think it gives me a message that I can't share a screen while the other participant is sharing. I don't know why. Yeah.
Yeah.
Here we go. Okay.
Okay, now it's clear.
Here. Thank you very much, Dr. Ahmed. Thank you, Dr. Omar. It's really a great honor and pleasure to be with you here. I'd like to thank all my colleagues for the great talks they gave. It's always very difficult to present after great talks and great coverage for this important topic. So I try to cover an important aspect, which is the differential of this skin rash. As the introduction was made at the beginning, now we learned a lot from COVID. And we learned also from COVID, especially as dermatologists, we had lots of atypical skin presentation. So there was nothing really specific. If we see the rash, we can say that this is a rash of COVID. However, in monkeypox, fortunately, there are lots of features that you can pick up early and can give you a clue that this could be a monkeypox. So here today, I'm going to cover the differentials of monkeypox. Now, just as the basics, and I guess all of you are familiar with your dermatology experience during medical school or residency training. Now, we always, as dermatologists, care about what we see as a primary lesion. We don't care much about secondary lesion because these are non-specific. So we want something specific. Accordingly, we can think about what the differentials could be this. So what we have a classical and for monkeypox eruption, that it belongs to a category what we call vesiculobullous. So you see vesicles. Yes, you can see any primary lesion, probably at the beginning, as my colleagues mentioned, it can present with even a little bit of macule that rapidly develop into papule and later on into a vesicle or pustule. So vesicle pustule, basically pustule is filled with pus, vesicle filled with water. However, with secondary lesion, once it scabs, once it's crossed, it's not really specific for any dermatological condition because any condition can end up with a crusting. So you need to look at certain criteria in order to confirm your diagnosis. Now, this photo has been everywhere in social media, in media, in the literature itself, everywhere. So this is the classical photo that's been linked with monkeypox. But is this pathognomonic for monkeypox or can be seen in any other skin conditions? In fact, yes, it is very characteristic for this monkeypox or smallpox specifically. However, this is not really very diagnostic because it can bring lots of cases that can mimic exactly the same presentation. So don't expect to see the classical textbook case as we always describe, or classical textbook photo in every case. So this is why you have to open your mind, open your eyes. And this is a message, in fact, to my colleagues in the emergency department or family physicians, general physicians, because probably they are the one who are going to see those patients at the beginning. So don't link this photo to your mind in order to say, yes, this could be a case of monkeypox, because the presentation early, you may not see the classical feature as you've seen in reported cases or published cases. Now, this is a classical presentation for chickenpox or varicella. Interestingly, probably my colleagues in family medicine or even in emergency departments, probably they are more familiar to diagnose these cases even more than us as dermatologists. Why? Because they do see them at the first presentation. So sometimes can be really very similar when you see vesicles that eventually will open and scab. What is characterized about monkeypox, as all of you read probably in the literature, it can present on face, can present on the acral skin. What we mean by acral skin on hands, you can see it in the feet, and later on can present at any part of the body. Now, from those who have seen the cases, whether suspected cases or even confirmed cases, one of the classical features that probably not talked a lot about in the literature about the reported cases, the affection of the genital area. There are most of the reported cases we're talking about face and acral skin. However, in the recent cases, we've seen lots of cases in the genital area. So keep your eyes open, and if patients are presenting with this, always it would be a good idea to look at the genital area. So this is a classical presentation of chickenpox, can mimic the other condition. Now, once the monkeypox news came out, now lots of fear in the community about anything that looks filled with water that can be monkeypox. And definitely most mothers, when they see their kids, the second day with vesicles on their palms, they would scare. And I've received lots of emails and lots of questions about this could be a monkeypox in their child. Well, definitely this is a classical feature, as you can see here on the hand. You can see it in the palmar, in the plantar aspect of the foot, and around the mouth. Yes, all of you, I think you mentioned it. I can hear you. This is a classical presentation of hand-foot-mouth disease, enterovirus, that can present with vesicular eruption, which can mimic lots of other viral infection. Yes, it's more common seen in children. However, yes, we can see it also in adults with sometimes a typical presentation, not necessarily only localized to palms and soles and mouth. You can see it on scalp. You can see it scattered on the body. So these kind of vesicular eruption sometimes can also mimic monkeypox presentation. As you can see, this is another case. You can see it in the palm in adult, and another case in adults. Now, another blistering condition or vesicular eruption can present also in palms or even in soles is that what we call, let me show you another photo, which is more classical. As you can see, all these are vesicular eruption on palms, and characteristically, we can see it with this hydrotic eczema, or known as Monkeypox. Now, can we differentiate? Yes, of course, very easy. History. This is why the most important aspect when it comes into confirming a diagnosis, not necessarily sometimes with the look, with the history, proper history, you can confirm the diagnosis. So you can see these deep-seated vesicles, which is characteristic for this hydrotic eczema, which is known also as a Monkeypox. So that can rule out any other viral infection in this presentation. Another also condition can present with blisters, especially on palms, and can be on soles. This is what's known as target lesions. And yes, this is a presentation of erythema multiforme. So classically, those patients will present with, prior to the eruption, with herpetic infection or sometimes medication. What makes it a little bit sometimes difficult when patient will come, will tell you, yes, I had a fever, I was not feeling well, a little bit of body ache. Even sometimes if you are unlucky, you're going also to palpate some lymph nodes, but you can see the classical target-like lesions. And of course, by pathology, this is very diagnostic by pathology to confirm the diagnosis. So this is another differentials for a monkeypox presentation. Now, this is what I call the great mimicker. You can see the necrotic lesions at the center. You can see some of the vesicular eruption in the lower photo on the right side. You can see a little bit of papular eruption. So all of these can, of course, fit into the differentials, or even you can suspect monkeypox virus. However, this patient will tell you in the history had a lesion that healed up on the genital area. So this is a classical presentation for secondary stage of syphilis. This is what I call the great mimicker. Now with syphilis, patients can present with any presentation, can be vesicular, can be with the classical presentation that all of you are familiar during your study in medical school or residency training. However, those patients, of course, you have to take the history, proper history. What makes it sometimes even difficult, because also some of the recent reported cases, especially from Europe, most of them came of the community of men having sex with men. So those patients, most of them, of course, they will give you a little bit of history of sex contact. So this is considered part of the sexually transmitted disease. Another condition also can present, especially in the genital area, lymphogranuloma and venereum, and another one with that's sexually transmitted also can mimic the presentation. Now, this is the classical presentation, as my colleagues also pointed out. The lesion later on will end with a little bit of necrosis and later on will scar. That, of course, you have to keep it in your mind. However, any lesion can centrally get necrotic, whether the classical viral infection or even as varicella or monkeypox. This is a picture in a child. If you can see a little bit, maybe you can, with some imagination, you can see the central umbilication or maybe a little bit of necrosis even in the center. So this is, of course, an exaggerated case seen more commonly in immunocompromised patients. This is an HIV positive child. This is a case of molluscum contagiosum virus, which is also a pox virus. That's completely different than monkeypox. So this is why you have to take the history. You have to look at the primary lesion. Looking at the secondary lesion probably will not be that much diagnostic. So if you see a lesion that's scarred, try to search to look in other areas that would be more diagnostic for you. If you look at the vesicle, then you know this is the primary eruption was vesicle. However, in this case, molluscum contagiosum, it is not vesicle, it's centrally umbilicated papules. So this is a case of molluscum contagiosum. Another case of molluscum contagiosum, some of them are centrally necrotic, as you can see in the upper right side, that's centrally umbilicated, but not linked with monkeypox. This is another classical presentation of pox virus as monkeypox or even smallpox. Both of them can mimic each other and can look like exactly identical and the same, but that usually seen on the face. Another classical case where you can see the central necrosis. However, again, you have to look at the primary lesion. You will see the vesicular eruption. So as a reminder, what we care about, how it starts. As you can see in the upper photos, they start as a vesicle or can be a papule or can be pustule. And usually they end up like these or as scabbing at the center, which is very also diagnostic for monkeypox skin eruption. So with this, I'm finishing my talk. I hope now you have an idea about the differentials. In fact, we have lots of skin differentials that probably would take an hour to cover all of them. Thank you very much.
Thank you very much, Dr. Anwar, for this very important session. We'll now open the floor for the discussions. We have many questions, so try to summarize them to each speaker, and we'll ask one speaker at a time. So, first question is for Dr. Fatima. Any theories on the current spike of monkey virus as compared to previous years?
So there's genetic sequences that is underway. So three things that how outbreaks happen: either chance events, there's virus spillover, change in virus characteristics, so that's the evolution of the virus, and then change in population, which the virus spreads. So experts are between those two. Is a change in viral characteristics. DNA viruses tend to be very hard to mutate, not like RNA viruses like COVID. There's been a lot of sequencing happening. They've identified changes. Now we need to be careful. If you talk to any geneticist colleague, they say a couple of SNPs of deletion or a couple of changes, we don't know the significance of it. So that's one. The other one is that the origin is from the African continent. We don't know, they don't have the full sequence, so there might be some missing sequence. So it's very important to take whatever genetic sequences that comes out with a grain of salt until we have a bigger picture. The third way is change in population, is the virus needs just a setting. And the setting in the European countries was rave parties. It was parties with a lot of sexual contact. So sometimes the virus just needs a setting to spread. So it's between those two, either changes in viral evolution or it's just the right time for the virus, finds the right population to spread.
Thank you, Dr. Fatima. Next question is for Dr. Hussein. Who's at highest risk for the infection And from the current data that we have, is there any reported coagulation derangements and what inflammatory markers are expected in this setting?
Shukran. I will answer the second question, which is the easiest one. As it was mentioned that this astaghfirullah, this monkeypox, this monkeypox is not the central African, is the West one, which is milder disease. So the first case we had, actually, we did initial full labs, liver, renal function, CPK, rhabdomyolysis, everything. Everything was completely normal, except mild CRP. So I will not say there is standard labs, and I will not recommend that you do a labs if you decide to admit the patient to minimize the contact with the staff, because they have to do blood collection, they have to avoid some lesions. So only treat the skin and do not expect local complication, unless, which takes me to the first question, the patient has a heart failure, has a COPD, has a chronic liver disease, then you may do some labs based on his condition. Dr. Emmanuel mentioned that, of course, in any disease, more immunocompromised can get more disease, but we don't know. We are learning, by the way. So at this stage, it's a new disease. I've seen one single case in my life, which is the one I have now. I would say everybody is exposed, except if you are vaccinated against smallpox, then you're less likely to get the disease or you get severe disease.
Okay. Thank you, Dr. Hussein. The next question is for Dr. Menon. What is the significance of the sequencing of the virus? And number two, what is the duration of possible expected positivity of the PCR and the role of the antibody testing?
Thank you for the questions. So sequencing is currently a very theoretical exercise, exactly like as Dr. Fatima said. It will help, probably understand in the long run the genetic relatedness between various strains which have been isolated. So to me, this is probably the most important relationship which can be given by sequencing. In terms of clinical significance, I think differentiation between clades is very important. And that is probably can easily be achieved by a lab-developed test which differentiates between the two clades, looking at various genes which are present on the virus. So the second question was
the duration of the PCR positivity and the role of antibody testing.
Yes. So the duration of PCR positivity is supposedly linked with the presence of scab. Even till the last scab is present on the individual is infective and should be treated as so. So one should be very, very careful in treating patients with monkeypox virus till the last scab has gone away. And as far as antibody is concerned, it is a very good tool to determine whether the individual has had an infection. However, it is important to remember that the antibodies, the current way we test it cannot really differentiate between smallpox and other orthopox virus infections. So it just gives you a kind of an idea whether this individual has had an orthopox infection or not.
Yeah. Thank you, Dr. Menon. The next question is for Dr. Sotibo. What is the current recommendation for the isolation precaution duration and the infectivity rate?
So, in terms of isolation, I think that was a question for Dr. Nawal, but Dr. Nawal, I can answer that if you'd like. In terms of isolation, when the patient is infected, you would want the lesions to completely crust and dry up, and you also do not want to see any new lesions. So the criteria we'd use in the UK was no lesions for over 3 days. The lesions have completely dried off, but we also use virological criteria. So negative PCR from blood or throat. Now we don't always have to use that. It depends on the context where you are and the resources you have. But from a clinical point of view, what you want to see is the patient is better, no new rash, and the rash has completely dried all. And that tends to take, unfortunately, it tends to take time. They don't get better quickly like chickenpox. It takes weeks, unfortunately. And that's why they tend to be in hospital for 3 to 4 weeks before discharge.
Thank you. One more question for you also is if you have a patient who's coming with the typical rash, but the PCR is negative, how would you manage this patient?
So, like most infectious disease conundrum, epidemiology is always right. So if the epidemiology fits and your test is negative, you don't discard your diagnosis. You keep the patient under isolation, and you take repeat samples, because the sensitivity also depends on the quality of the sample and also transportation. So if the story still fits, the rash still fits, you do not discard your diagnosis. You speak to the infectious diseases, speak to virology or microbiology, and then we'll decide what tests we're going to do, and we continue treating as monkeypox until we have an alternative diagnosis.
Thank you, Dr. Many questions for Dr. Nawal. That's why I'm trying to disseminate to others. So, Dr. Nawal, what is the role of the vaccination on previous smallpox infection in the prevention of the future monkeypox? And is there a role of chickenpox vaccine in the prevention in this case?
Thank you for this question. I'll start with the second question. So there's no role whatsoever with chickenpox vaccination. I think there are misunderstanding that people thought more or less it's belong to the same group, but it's not. So there is, we assume there is some protection from smallpox that was discontinued in 1977. However, we are a young population, and most of this GCC are young population. So most of the people will not be protected. Now, thank God, it is not a high risk it is not highly transmissible till now. So the vaccination, I don't think, because I know there was one vaccine about mass vaccination. At this stage, with the current information, with the current data, we don't expect mass immunization. Immunization will be limited to pre-exposure for certain group, like the lab who are dealing with the monkeypox, certain workers who will look after monkeypox or public health, maybe military for the pre-exposure. For the post-exposure, it will be limited to the close contact, whether they are household or within the same dorm, or they are living together, or in unprotected exposure in the healthcare setting.
Is there any role of the IVIG in this?
Okay, so there is an IVIG specific for smallpox that likely will also react for a monkeypox. It's being requested, but I don't know if we'll be able to get it. Now, the role for IVIG is mainly, in the past, was mainly if you cannot give the vaccine for the close contact due to severe immune deficiency or previous reaction to a similar vaccine, then you might, and the patient at high risk of complication, then you will give vaccina IVIG, but not for everybody.
Okay, thank you, Dr. Nawal. The last question is for Dr. Anwar. Two parts. The first one is, would the skin lesions leave any scar? And the second part is how to prevent the spread of the rash to other parts of the body and maintain personal hygiene. Is this possible?
Well, first, the second question, common question, in fact, till when the rash will be contagious, till they scar. This is similar to what we see with the varicella. Once they are scarred, they are not contagious anymore. The first question, whether they leave, well, depends on many factors. Very difficult really to predict. What we learned from varicella or chickenpox, affecting adults usually end up with, unfortunately, a little bit of scarring, post-inflammatory pigmentation, especially if the patient is picking them and playing with them, especially also with the sun exposure. We know with children, usually they heal better and doesn't leave that much of marks. So of course, we're going to learn a lot in the coming months and see a lot, because what we know right now, if it's the similar kind of features, I mean, definitely there will be what we call post-inflammatory marks or pigmentation, and the possibility of scarring is always there. If there anything needs to be done, apply, unfortunately, as topical medications limited, maybe something to dry them up, something like calamine lotion. If they are secondary infected, treat the secondary infection, whether bacterial or any other secondary infection. And later on, we can talk about whether it needs any kind of peeling agents or anything like that. So the possibility is there, but cannot be predicted. Depends on the patient and how the patients are healing.
Okay, thank you very much, Dr. Anwar. Fortunately, we do have a lot of questions, very good questions, but due to the restriction of time, we're unable to address all of them. We'd also like to announce that we'll be also soon, inshallah, we'll be announcing the Emirates Infectious Disease Society. So stay tuned, and we'll have, inshallah, more interesting sessions to come. Dr. Umar, the mic to you.
Okay. First of all, I would like the ID team to stay with us with the Internal Medicine Society, but I think time will come and you will have your own society, inshallah, in the coming future. We received around 100 questions. I think 20 questions for each speaker. So if we continue to ask the questions, then we'll need like 5 or 20 cycles to finish. So I just want to just make one final comment. I've seen some monkeypox cases presenting with cough, sore throat, and fever and rash in the genitalia. So I always tell my physicians, not every cough is COVID, and please don't forget to examine the private area if indicated. I would like to ask the final question to each speaker. We'll go around the table. So I want to ask, do you think monkeypox will become a pandemic or not? So we will start with Dr. Anwar. He's in my right side in the screen. So Dr. Anwar.
Inshallah no. Inshallah no.
Inshallah not. Okay. Dr. Ahmed.
Well, no, I don't think so. I hope that will not happen. I think we learned from the previous COVID pandemic, and I think this is much different virus in terms of transmission, and we have the previous knowledge about this. So inshallah, this will not be the case.
Inshallah ta'ala. Dr. Emmanuel.
I think I agree with my colleagues that it's very unlikely that we're going to end up in a pandemic because of the characteristics of the virus, transmissibility, and the current population in which it's spreading. And so I think it's highly unlikely that we're going to end up in a pandemic. And I think this will be controlled, inshallah, in a few weeks or months.
Inshallah. Dr. Nawal. Dr. Nawal, we need another session with you because I received around 30 questions that just directed to you. So what do you think?
Okay, thank you for this question. Now, I don't think it will convert to pandemic, but what I am almost 100% sure, it is already it's a multi-country outbreak. By the way, one case considered an outbreak. And I think it will be more endemic. I do believe at this stage, it's almost in every single country. The reason they didn't announce it because they don't have an access to the PCR. The disease should not be stigmatized to homosexuality, as all the ID physicians see cases that has nothing to do with the homosexuality. So, and we have to be extremely careful not to make the same mistake as it happened with the HIV. So I think, unfortunately, if we don't act as one, like all the country act, because it's been there for 50 years and nothing happened. The reason that it got all the attention because it's been discovered in the well-developed country and start to spread. That's why everyone thinking of the vaccine and treatment and management and isolation. Well, if you ignore any disease, that's what will happen. So we cannot ignore any disease. We have to act. And if there is one outbreak somewhere, it could move within a few hours to another country. So as I said, I do believe will spread in all countries. I do believe it will become endemic. I don't think it's pandemic. Maybe the terms a bit different, but we need to work all together to prevent it. In terms, we know now how it spread, so everyone should follow the precaution. We have to teach the public how it's spread, and use the vaccine for certain groups, and manage all the cases, whether it's in US or Africa or in the Middle East. I mean, human are human, and we have all to take care of each other.
Inshallah, very well said. Thank you so much. Dr. Menon?
You know, having been in infectious disease for last 30, 40 years, I like to think of any disease outbreak as an iceberg. You know, in the sense that you only see 1/10 of the cases, really speaking. And what worries me is the sporadic appearance of cases which are totally unrelated to each other. So this shows, as Dr. Nawal said, that this is there in the population. Important thing is to recognize the fact that this disease exists, continue to monitor for it, ensure that we do not stigmatize it so that people don't hide it, and then look at the best possible way to, look after sub-communities which may probably be more prone to this disease than otherwise. For example, immunocompromised people, people who have got transplants, etc., etc. So that is my thought on this.
Thank you so much, Dr. Menon. So, Dr. Fatma, what do you think?
I think my co-panelists have said really great things. I really echo what Dr. Nawal said about global health. I think we need to consider ourselves privileged that we have strong healthcare systems, and that, like Dr. Nawal said, if it's in one country, it's probably in many, many more, and it's the tip of the iceberg. One thing I want to highlight, if we learned anything from COVID, of course, monkeypox is different. The COVID vaccine can be given to immunocompromised patients. That's not the case with monkeypox. COVID, at least with Delta, Omicron is different, has not hit children as much. With monkeypox, as we know from cases in the African continent, it has. So if we need to not be selfish at this point. We need to protect our most vulnerable community. And if we learn from COVID, like we tell them, the public to mask, like we tell the public to vaccinate, not just for yourself, but for others. I think we need to hone in that message more and more with monkeypox.
Thank you so much. Very well said. Last but not least, Dr. Hussein.
Thank you very much. I do not think it will become pandemic as a definition, pandemic as COVID, for 4 reasons. Number 1, we already have a smallpox vaccine, which is protective against monkeypox. Number 2, all the countries, especially United Arab Emirates, we have the infrastructure how to fight infectious disease. We have all our COVID hospital field, so we are ready for it. So our protective measurement is already there. That's why it will not become pandemic. Number 3, it's a DNA virus, not like RNA virus. They less mutate, less variation, less different. And the 4th reason, which I answered my son yesterday, he asked me, Baba, you think they will shut down the airport, the school and house and street and everything? What do you think? So I give him the 4th reason. I say, no, this disease comes in the skin. So when the people have a skin disease, they will hide by itself. It's not like COVID. You may have low-grade fever, you will go outside. But when you have a skin rash, you will hide inside. It's stigmata. So less likely to become pandemic. So 4 reasons.
Thank you so much. Thank you so much, Dr. Hussein. And the reason I asked this question to the expert, that I want to reassure the healthcare providers that we are in a good shape. And in my opinion, I echo all the speakers. I don't think this will become pandemic, especially for the reason mentioned by Dr. Hussein and Dr. Nawal. Thank you very much for this amazing session. We had very informative webinar, and I hope to see you in the future with another session, inshallah ta'ala. have a lovely night, and we'll see you inshallah in the coming future.
Thank you.
مع السلامة.
We reached
Thank you.
1,000 participants. That was great achievement of the Internal Medicine Society of UAE Society. إنجاز عظيم لكم صراحة. Thank you very much.
الله يعطيك العافية دكتور، وإن شاء الله you will see the same with your new ID society إن شاء الله تعالى.
شكرا. تصبحوا على خير.
Thank you.
Thank
And
you, and
thanks
good night,
for
everybody.
organizing committee behind arranging all this, Mr. محمد جنيدي. شكرا محمد.
شكرا ايكم، شكرا محمد والفريق كله ما قصر. الله يعطيك العافية. Thank you.
Thank you very much.
Thank you. Bye-bye.
السلام.
مع السلامة. مع السلامة.